In this small intestinal lecture segment, I'm going to talk a bit about obstruction, also known as mechanical ileus. A mechanical ileus is some sort of structure that prevents the flow of normal digesta through the small intestine. Early on, the small intestine that's ORAD, or proximal to that lesion, is going to be hyperperistaltic and is going to try to push against that obstructing agent. And so some agents, some foreign objects that may initially cause obstruction could ultimately pass. However, if the material or the mass doesn't move and continues to cause obstruction, there is going to be fluid buildup and gas buildup ORAD to the lesion, proximal to the lesion, and the peristalsis will ultimately decrease. And that's what we see as ileus, or intestinal dilation. So radiographically, generally speaking, the intestine that's ORAD, or proximal to the lesion, is usually dilated, and the part of the intestine that's distal, or ab-ORAD, to the lesion is not dilated and is usually empty because nothing can get there. And that's what we are talking about when people refer to two populations of small intestine. There's one portion of the small intestine that's normal size, and that's the distal part, and then there's one portion of the small intestine that's larger. So you've got two different sizes. It doesn't have to do with gas and fluid content or anything like that. It's two different sizes of intestine. You do have to be careful not to overcall that two populations, though, or else you're going to do a lot of negative explores on dogs who aren't actually obstructed. So there is normally some variation in small intestinal size because some loops may have material in them while others don't. There's varying degrees of peristalsis at any moment in time. So you have to be careful not to call two populations if all the segments are relatively normal in size. So nobody is bigger than a vertebral body height. And also don't call two populations if there's not much difference between the two segments. A few millimeters is not worth a mention. And you can go back to the rules of thumb as to considering how big is too big. In a dog, I start getting particularly worried if small intestinal height is greater than 2 times the height of the L5 body. In a cat, more than 4 times the height of an L2 end plate. And then if one segment is more than twice the size of the more normal or smaller segments. But you can't just base everything on measurements. You do have to use all your other findings, both radiographic findings and clinical findings, to put the whole picture together. So here we have a vomiting puppy, and when I first look at the radiographs, I see that there are a lot of intestinal segments that are very dilated. And in reality, there's just too many to be colon. So remember, my first thought is, could all of this be colon? And here there are just way too many to all be colon, and some of them are pretty ventral to be colon as well. And so when I measure the largest of these relative to the height of the mid-body of L5, which is what I'm supposed to do according to the literature, I see that the largest of these is more than 2 times that height. So that's going to be highly concerning for an obstruction. And I can also see that I have 2 populations of small intestine. I'll take the green away again, because I have multiple gas-filled small intestinal segments that are normal in diameter. So this big one is much, much, much bigger than those. So we definitely have 2 populations, and that's a mechanical ileus. There's an obstruction due to something. Here we have the same patient on the VD view. Again, lots of intestines that are way too big and way too gassy. Even if this is colon, probably, there's no way all of these gassy loops are colon. And so we definitely have gas-distended small intestine. There again are your few normal ones, so we have 2 populations of small intestine, and we can diagnose a mechanical ileus. One thing to remember is that those dilated segments might be fluid-filled or gas-filled, and they're really easy to see if they're gas-filled, and they may be a lot harder to see if they're fluid-filled, but you don't want to miss the diagnosis on the basis of easy to see or not quite as easy to see. So you do want to look at the fluid-filled segments as well. When you see gas distension of the small intestine, that is more commonly due to an acute process and is more commonly due to a complete obstruction, whereas a distension with fluid or some component of ingesta often indicates a partial obstruction and a more chronic process. And that's because when an obstruction happens, usually gas is the first thing to accumulate there because the patient's going to be aerophagic. There's going to be some swallowing of air. There's also some gas from bacterial fermentation. as time passes, some of that gas can get out. Some of it may sneak around the obstruction. Some of it may be absorbed into vasculature. And as that's happening, there's actually fluid accumulation. As the small intestinal wall gets edematous, fluid oozes into the lumen, and the mucosa also fails to absorb anything that's in the lumen, and so there's further collection because of that. So usually we see gas early and fluid late, and so the distinction with gas versus fluid can help determine whether this is a more acute or a more chronic problem. In this cat, I see that the stomach is markedly distended with both gas and fluid, and I can see that there is some fecal material in the colon, so I've accounted for a good bit of large intestine, and so most of the other intestinal segments that I see are going to be small intestine, and I see that there are a number of them that are bigger than I would like to see. They're all fluid filled. There's really no gas here, at least not any appreciable amount, just a couple of bubbles, in the midst, but mostly fluid filled, and these are too big, and they are bigger than some of these smaller ones. So again, we've got two populations of small intestine and a mechanical ileus. Same cat, ventrodorsal view, again, giant stomach, and a very big duodenum, and it's fluid filled. I'll take the markers away again. So you can see that very large fluid filled duodenum compared to the more normal jejunum that you see caudal to it. So once again, two populations of small intestine. Here it is fluid filled. Again, it makes the edges a little tougher to see, but it's still important to make this diagnosis. How much distension you see of the intestine is going to vary patient by patient because the amount of obstruction is going to vary patient by patient. Most cases are not purely 100% obstructive. Often a little bit of material, fluid, gas can get past an obstruction. It's not yes or no, it's not all or none. So you can have a partial obstruction all the way to basically a complete obstruction. When there is a partial obstruction, you may see a gravel sign, which is where mineral opacity material can settle out or will settle out just proximal or just orad to the obstruction. And that suggests that we're going to see that right here. So in this vomiting dog, again, I see a distended stomach. It's moderately distended with gas and fluid and maybe some heterogeneous material, including some mineral. And then I actually see some mineral in several other places. There are a few small intestinal segments that are pretty normal, little gas in them. And then there's a gigantic fluid-filled segment here in the mid-abdomen. There's a serosal edge, there's a serosal edge. I think it's easier to see down here. Serosal edge here, and then down here. So you got this big fluidy tube all the way through there, which is way bigger than any of the other intestinal segments and is not running the right way to be the colon, especially when I see that I can account for most of the descending colon here. So go back through, distended stomach, gravel signs, there's a material in the pylorus, and there's, again, our gravel that is associated with this big distended loop. So again, is it 100% that it's colon versus small intestine? Hard to say, but given that I can see most of the colon there, and it seems like it's outside the plane, and then I have this big small intestinal loop here, and it's in the plane of that, it seems like it's associated with this large loop and probably relates to the site of the obstruction. Same story on the ventrodorsal view. A little harder to see all the various loops, but I can still see the material, and which is compatible with the gravel sign. Radiographs, we didn't see the cause of obstruction. Since it's more likely to be chronic with this, a chronic partial obstruction, I'm always more concerned about something like a mass, like neoplasia, rather than a straight foreign object, but it still could be foreign material. The degree of distension that you see when it comes to the small intestine is going to be determined in part by where an obstruction is. So an obstruction that's very proximal, such as the duodenum, may not produce much small intestinal dilation because most of the small intestine is distal or ab-orad to the obstruction, so most of it's going to be relatively empty. And any distension proximal to the lesion is in the very proximal duodenum, and that may reflux into the stomach, and so you may not see much in the way of intestinal distension at all with a proximal lesion. I do look at, though, disparity between stomach and an empty small intestine. When I see a giant stomach in a patient who's vomiting and the small intestine's pretty empty, that always raises concern for either a pyloric outflow obstruction or a proximal duodenal obstruction, because the GI tract should be a big tube. And so if one thing is full, everything should get kind of full. And so if one thing is full and everything else is empty, there has to be some reason why there's not appropriate passage. And it could be functional, but I always get concerned about a relatively proximal obstruction when I see that. On the flip side, you can have a very distal lesion, a very distal obstruction, and there, most of the obstruction is upstream, is ORAD, proximal to the lesion, but there may not be as much distension because there's so much capacity of that much small intestine to take on the fluid or the gas that it may not distend very much until pretty late in the game. And so that can actually look more like a functional ileus, where none of the small intestine is normal because nothing is distal to the lesion, but nothing is all that distended either. And so that can make for a more challenging diagnosis as well. This is an acutely vomiting cat, pretty fat cat. It's got pretty good serosal detail, which is nice. And right on, I see that there is some sort of kind of square-ish mineral opacity object. Exact location tough to tell on this view. Could be the pylorus, could be small intestine, could be large intestine. And the interesting thing is none of the GI tract is particularly distended. And I'll look on the VD view and we're kind of in the same situation. I don't think it's colon because I can see the margins of the colon. I can see where the gas is and it seems like it's outside of that. But it still could be in the pylorus or the duodenum. Either way, that's concerning. And, you know, in a vomiting cat who has this foreign object in the area of the pylorus or the duodenum, I'm concerned that there's an obstruction. There's not much material getting to the small intestine, so it's relatively empty. And then everything proximal is really just the stomach, and that's relatively easy to empty via vomiting. And so that's probably why this patient doesn't have anything that's overly distended. When I have evidence of a mechanical ileus on radiographs, I have a number of differential diagnoses. Foreign material is very common in our veterinary patients, but it's certainly not the only differential. Think about intussusception, especially in younger patients, potentially with parasites, or older patients who might have neoplasia. Any sort of mucosal or mural mass, neoplasia, granuloma, stricture or adhesions from previous injuries or insults, or even an extramural mass that compresses the small intestine. Mass is not as common, although we will see hernias causing some problems every now and then. And always remember that you may not see the cause of the obstruction on survey radiographs. If there's foreign material and it's radiopaque, that's easy, but a lot of foreign objects are soft tissue, opacity because they're cloth, and so you may not see them as a discrete structure, or maybe you get a hint of it, but it's not convincing. But if there's evidence of an obstruction, you're going to have to go to surgery and go looking for it, even if you don't see the absolute agent. So we got another vomiting patient. This one's a dog. And here we have, again, evidence of two populations of small intestine. There are some larger segments that are not going the direction of the colon, and there are some smaller segments. This looks like colon right here. So we do have two populations of small intestine. So given that, I'm quite convinced that we have an obstruction. And then the question is, can we find where the cause is? Again, sometimes you can, sometimes you can't. If I zoom in on this caudal area back here, something that draws my eye is right here where we have this almost rectangular area where it's kind of striped. It's got gas, it's got some soft tissue opacity, and that's what a corn cob often looks like. We'll go to the other view. We see similar things. We've got two populations of small intestine. That caudal segment is almost certainly small intestine because the descending colon should be on the left side, not the right side. And if I zoom in on this caudal area on the left, again, I see this kind of ill-defined spot structure where we have some stripes. And again, corn cob foreign object is going to be my primary differential, although some other foreign object is possible. On the flip side, remember that presence of a GI foreign body does not always indicate that there is an obstruction. We will see incidental foreign material passing through that may not correlate with any GI signs whatsoever, or even if there are GI signs, it could be due to irritation, gastroenteritis, and maybe still not an obstruction, so it may not require surgery. So even if you see foreign material, you still need to look for evidence of mechanical ileus before you're going to go explore this patient's abdomen. So this is a dog who was actually here for a cardio workup, and we saw a lot of mineral opacity, thin-rimmed beads in the stomach and intestines. This dog had no clinical signs for GI disease, and there's no distension of any part of the GI tract. So this is incidental. It's at least at this point, there's no evidence that it's causing any problem. Here's an older cat who does have GI signs and weight loss. And right away, we see that there's some abnormal opacity in the GI tract. There's some mineral opacity material in the stomach, in the intestines, and this loop of intestine is pretty distended. Could be colon, could be small intestine. So there's definitely abnormal material. At least some of it is definitely in the colon as you go down to the descending colon. So at least some of the material gets through. And the question is this material actually the cause of the vomiting or not? Since some of it's getting through, it seems like it's not obstructive, although it certainly could be irritating. What's perhaps more relevant in this case is that there's this big soft tissue opacity mass or masses in that middle abdomen, as well as some decreased detail kind of through there. So I'm concerned about mesenteric masses, such as giant mesenteric lymph nodes or some small intestinal masses, any of which could very easily be neoplasia and might be the ultimate cause for the patient's clinical signs. So that's it for round one of obstruction, and in the next intestinal segment we will talk a little bit more about other obstructions.